Over to you, Dr. Chinmoy.
Okay. So, thank you, Dr. Varsali. Thank you, Dr. Anshul. So, I'm starting the presentation. So,
Sir, you can share your screen, please.
yeah, I'm sharing. Yeah. So, USG of hip and ankle. So, uh, these were the agendas that common pathology. First we'll go with the common pathologies because actually I don't want to talk about the anatomy, sonoanatomy, just like that. I mean, like of the total area which is required. The anatomy we should know about that area which is required for identifying the mainly pathologies. If that is not required for a pain physician, that's what I am not talking. Okay, so and then ultrasound anatomy also. After common anatomy, will 3D anatomy, we'll go to the ultrasound anatomy and some pathology part. Then interventional techniques we will talk about. Then some procedure protocols. So protocols remains fixed for most of the procedures, and then outcome evaluation. So common pathologies. So now common pathologies. Let us see that common hip pathology at a glance. If we see, then greater trochanteric pain syndrome. So, think that in a hip pain patient, the pain can be in the front side, can be in the lateral side, can be in the back side of the hip. So, in every area, there are multiple diagnoses which can cause the hip, which can be a cause of hip pain. But we are talking about only few entities which are very basically common entities. So greater trochanteric pain syndrome is actually it causes pain in the lateral side of the hip. Now gluteal tendinopathy, different types of tendinopathies, like say gluteus medius or gluteus maximus or gluteus minimus. These tendinopathies, they also cause the lateral side of hip pain. So together we can say, and some bursitis. These tendons have I mean, wherever when this inserts in the greater trochanter, then below these tendons and between the tendon and the bone there are some bursas. So these bursas can also cause bursitis. So these tendinopathies and bursitis together, they can cause greater trochanteric pain syndrome. Then another pain syndrome is posterior side of the hip, that is we call that deep gluteal pain syndrome. Earlier we always knew about the piriformis syndrome, but then gradually we understood that only piriformis syndrome. Why to blame directly only piriformis? There are multiple muscles like gemellus superior, gemellus inferior, obturator internus. So these are muscles at the same area, and there are some ischio-gluteal bursitis also can present in the same way. So together everything, I mean, that can be described under deep gluteal pain syndrome. Then labral tear and femoroacetabular impingement, that is not very common, but it can also cause a basically both anterior and posterior side of hip pain. And in this type of pain, of course, after the symptom, from the symptom, when you make a diagnosis that probably there is a labral tear or there is a impingement, then this diagnosis should be made by the MRI. Directly we cannot see from the ultrasound, we cannot reach at a diagnosis. Then some iliopsoas pathology, iliopsoas bursitis, tendinopathy, internal snapping hip syndrome. So these are all related to the iliopsoas tendon actually. So iliopsoas tendon or below there is a bursa. Then some hip joint arthritis, that is the most common. Hip osteoarthritis, patient can come with groin pain. So we can see the effusion also. So these are the common pain syndromes which we get in a pain clinic in the hip areas. Then some other pathologies which are directly not in the hip joint area, but while examining by ultrasound, we have to see in the hip area. So that is one of them is the meralgia peristhetica, and another is say femoral nerve neuralgia or genitofemoral nerve femoral branch. So genitofemoral nerve has two branches. One is femoral branch, one is genital branch. Genital branch I am not describing because that causes pelvic pain. But femoral branch, that that can cause the pain in the front of the thighs. So these also come while we see the while we do the ultrasound of the hip, we can see these nerves also. Now, common ankle pathologies at a glance. So in the ankle, mostly there are only few tendons and muscles there in the ankle area. So mainly the Achilles tendinopathy. If we think about the posterior compartment actually, so Achilles tendinopathy, retrocalcaneal bursitis, these are the very common entities in the ankle. Then comes some tendons, those who are around the tendon, most of them can get affected in case of inflammatory arthritis. Those who have rheumatoid arthritis or gout, in those cases, patient can have these tendons inflamed, like peroneal tendon pathology, peroneal tendinitis. One can have, or tibialis posterior dysfunction, or say. So these tendons can get tendinitis or tendinopathy. Both the things can occur. Tendon tear also can occur. Then comes ligament. So in the ligament injury of ankle is nothing but what we call as sprain. So sprain can occur in the medial side also, it can occur in the lateral side also. If in the medial side it occurs, then it will be called as most of the time it affects the deltoid ligament. And if it affects in the lateral side, then it is lateral side sprain, and ATFL, anterior talofibular ligament, that ligament is affected. So ligament also can get affected in the ankle. Then anterior impingement or joint arthritis, means tibio-talar joint. Main anterior side joint is tibio-talar joint, which is the actual ankle joint. So that joint patient can have arthritis, or anterior impingement also can occur. So these are the common pathologies which we see at the ankle level. Now, to see the first, let us see from the let us go to the hip part first. So in the hip part, let us see the anatomy. So just few things we must remember to see before seeing the sonanatomy. This part we must remember. So in the hip part, we can think that from the front side, anterior side, and then in the posterior side and lateral side. If we consider in this way, then we will remember the muscles in a better way. Of course, medial side is also there. So medial side is called adductor compartment. Anyway, so anterior thigh, anterior hip, I'm saying. So anterior hip, what are the muscles? So remember here, if we think in this area, in the bony area, in the upper part, so this is anterior superior iliac spine. This anterior superior iliac spine, from there, two muscles arises, or there is insertion of two muscles. One is sartorius. This is the sartorius, and this one is the tensor fascia lata. So these two muscles we will see from the anterior superior iliac spine. Okay. Then in the so if I remove these two, then let us see the area of anterior inferior iliac spine. So from anterior inferior iliac spine, there is only one muscle, and that is the rectus femoris. So this is the rectus femoris. Let me hide it. So after that, so only these three muscles in the front side. These three muscles. Okay, one is sartorius, and then in middle part, this is the rectus femoris, and this side is tensor fascia lata. So only these three muscles in the front side. Okay, and another muscle which actually not a long muscle, which doesn't start from here. It starts from the lumbar spine area, and then it will come to join in the lesser trochanter. So this muscle is iliopsoas. You can see this one is the iliopsoas. So iliopsoas, remember, just in front of the hip joint, in front of the head of the femur, the muscle which we see, that is always iliopsoas. If I just remove this one, so you see, if that capsule I have removed of the hip joint, so after that you can see that just over the head of the femur, the muscle which we are seeing, that is the iliopsoas. Okay, so this one we should remember while we are seeing the front side of the hip. So first, while doing the ultrasound, first we will see from the front side, we will try to locate the head of the femur. As soon as we get the head of the femur, we understand our location, and just in front of the location, the first muscle we will see, that is the iliopsoas. Of course, by the side, what we will get, one is sartorius, one is rectus femoris, and one is tensor fascia lata. That is the anterior hip. We will not talk about these things because these are these are below greater trochanter, and from the these are the thigh muscles actually. Okay, vastus lateralis and vastus intermedius, those things. Anyway, so in the posterior side, let us see from the posterior side. So here, first muscle in the posterior side, that is the gluteus maximus, and then there are two other muscles, that is the gluteus medius, and if we see here, this is the gluteus minimus. So though they are the gluteus maximus, medius, minimus, they are basically covering the posterior side, but their tendons are inserted in the lateral side. If I remove this muscle, yeah, so their tendons are actually inserted in the lateral side. So here, this is the gluteus minimus. So here, this greater trochanter area, we can divide them into facets. So this greater gluteus minimus, they are entering here in the anterior facet, and this is in the lateral facet, gluteus medius, and above that, most superficial is the gluteus maximus, that is going into the posterior facet. So posterior facet, then lateral facet, then of course, gluteus maximus do not enter in the posterior facet. It is below posterior facet in the upper part of the femur, upper part of the femoral shaft actually. Okay, so mainly the gluteus medius, it comes in the lateral facet also, and upper part of the posterior facet also. And minimus, as I said, it is in the anterior facet. So if I remove all these three muscles, then we see the deep muscles. So what are the deep muscles? So these are the external rotators. These are called external rotators of the hip. So remember, first one is the piriformis muscles. So for a long time, we knew that piriformis syndrome it can cause the sciatica-like symptoms. So any time when the patient was, if patient is complaining of radiculopathy, and we see the spine is completely normal, there is nothing. Then second diagnosis, most common diagnosis comes to our mind, that is the piriformis syndrome. But later we could find that though piriformis syndrome not only produces the radicular pain as a sciatica symptom, it can cause localized pain also for its because it can cause a myofascial pain syndrome. Here also trigger point can come in the trigger in this piriformis muscle, and it can cause myofascial pain syndrome. So later we could find that not only this muscle, these three muscles can also get affected. So what are these three muscles? This is the gemellus superior, and this is the obturator internus in between, and then it is the gemellus inferior. Okay, so these three muscles. So just one thing here, you note it here, that if I put a probe in this area, in the just a bit. So in this area, if I put a probe, so what I will see, I will get three muscles: gluteus maximus, gluteus medius, and gluteus minimus. But if I put another the probe here in this area, uh, or say a bit up, like this. Okay, so first one was here, then I came here. Okay, so actually, while doing the ultrasound of the hip from the posterior side, we start from the we start from the posterior superior iliac spine, from here, posterior superior iliac spine. Then gradually we come here, posterior in this area. So here, what happens? So in this area of the number one position, what we will get? We will get three muscles: gluteus maximus, medius, and minimus. So what we will get in the position number two? So here we will not say we will not get medius minimus. We will get only maximus. So it is here, no? So gluteus maximus we will get, and below that we will get the piriformis. So this is the piriformis. So if now we come to, so after the position number two, if I remove this piriformis. So now I come to the position number 3. So where is the position number 3? This is the position number 3. So at this point, what we will get, then we will get the ischial spine. So in this position, what we will get? We will get the over the ischial spine, some gemellus superior, inferior, or obturator internus. These muscles we will get, and here, of course, we will not get the piriformis muscle. But then other two things can come. What are these? These two things we will see. We will see that this one is the sacrospinous ligament. It is coming from the ischial spine. This is the ischial spine. So this is the sacrospinous ligaments from spine to the sacrum, and above it another ligament is there, that is called sacrotuberous ligament. Okay, so this one is the sacrotuberous ligament going to the sacrum, but from the ischial tuberosity. That's why sacrotuberous ligament. So when in the third position we will see the ischial spine, but the two along with that, sacrospinous ligament and sacrotuberous ligament. Sacrospinous ligament will be at the same level of the ischial spine. Okay, this is the position number 3. Then let us come to the position number 4. So where is the position number 4? Position number 4 will be here in this area. So in this area, what we will get? We will get directly the ischial tuberosity and the semitendinosus, semimembranosus, or the biceps femoris, this conjoint tendon insertions. Okay, so at the, if I just here you show this is semitendinosus, and this one is the biceps femoris, and this one is the semimembran. No, this is adductor magnus. Anyway, here semimembranosus is also there, but this is basically the semitendinosus, semimembranosus, and this is the biceps femoris. So all these tendons insert at the ischial tuberosity. So that is the 4th position. So when we see the ultrasound hip, when we see from the posterior side, so we put our probe at the 4 positions. One is at the level of the posterior superior iliac spine, one is at the greater sciatic notch area, this area, and third one is at the ischial spine area, and fourth one is the ischial tuberosity area. So at these different areas, we get different structures. We see different structures which can cause different pain. So just to understand that, how do we understand that at which area we are there? We will see the bony margin. So at the area number 1, the bony margin will be like this. Okay, so one side will be much superficial, and lateral side will be a bit deep. So here you can see that this area is actually a bit slope. This is a slope actually. So when we will demonstrate, I will show you. So this is the slope you will see. Then comes number 2 position. So number 2 position, we will see that bone will be there. There is a gap in the bone. So we will see the bone of this part we will see, and this part you will see. In between we will see, because greater sciatic notch is there, so there will be a gap in the bone. Then comes number 3 position. In the number 3 position, we will see that this part will become a bit bigger like this. Okay, so third one. So this part is actually wider area. So this we will understand that this is the ischial spine. Fourth one, again we will see this way, small ischial tuberosity. This is the fourth. This all I am talking about the bony surface architecture. From seeing the bone, we can understand the bony margins. By ultrasound, we will see the periosteal margin. By seeing the bony margin, we will understand that where we are locating at that point. So why these different areas are important? So at the second number area, it is the piriformis syndrome. For piriformis syndrome, you have to locate in the number 2 position, so that you can inject in the piriformis muscle for myofascial pain syndrome or whatever. So That is the number 2 position. Why you need in the number 3 position? That is called pudendal neuralgia. For pudendal nerve is located here in the number 3 position. Why you need number 4 position? So you need to see whether it is there is a ischiogluteal bursitis or there is a tendinitis of the hamstring muscles, conjoint tendon, or all this biceps femoris tendon. So these tendons are having can have some tendinitis or ischiogluteal bursitis for this thing. Number 1 position is not for a disease actually. This is for location purpose. We start from there. It is a home page area. Okay. So this is the posterior side. Now let me show you the lateral side. Lateral side, already I told you that here only 3 things: gluteus maximus tendinitis, gluteus medius tendinitis, or gluteus minimus tendinitis. And with all tendinitis, there can be a bursitis associated: subgluteus maximus bursitis, subgluteus medius bursitis, subgluteus minimus bursitis. Okay, so these are from lateral side. So all these things are in the from the anatomy part. And medial part I am not talking about, because obturator nerve and all can be seen in the medial side. These are all adductor of hip, but then these doesn't cause the pain in the hip area. They cause more in the pelvic area pain. Okay, so this part I am not showing now. So after 3D anatomy, let me go to the some part of the more part of the anatomy. So this is the capsule. So you can see that capsule, how these capsules are coming over the hip joint. So this is the femur. You can see that actually there are 2 layers of the capsule. There are 2 layers of the capsule, capsular layer, which covers the this femoroacetabular joint, that we will see by ultrasound, no problem. So here, now one more thing is important here. When we are seeing the iliopsoas complex in the front side, as I told you that in the front side there are 4 muscles. So iliopsoas area, when we see, because when we will put the probe over the iliopsoas area, we will first locate the head of the femur, and just over the head of the femur we will get the muscle, that is iliopsoas. Just to I mean show you that at that area it is basically the iliacus. Here this red muscle, it is the psoas muscle. So you can see this white part. So this, you can see this white part, this is actually the tendon. So a lot of area is actually has become the tendon, this completely tendon. So this tendon is the psoas tendon. Okay, psoas muscle is much proximal. Okay, psoas muscle is here, and in this area, just over the head of the femur, this psoas tendon actually becomes a tendon. And at that area over the head of the femur, the muscle which we see, that is actually the muscle of iliacus. Iliacus has also has a tendinous part, that is iliacus tendon, and this is psoas tendon. Okay, so 2 tendons are different. So remember, at this point over the femur, what we see, all the muscle is of iliacus and only the tendon is of psoas. Okay, so this is just a anatomy part. Lateral femoral cutaneous nerve, they remain when we are seeing by ultrasound, we find it between the sartorius and tensor fascial lata. There we find we search for the lateral femoral cutaneous nerve. But studies have been done, and it has been seen that it is not always this in between these 2 muscles. It can be below the sartorius also, or inside the sartorius also. So different specimens you can see in the different areas, it is possible. Genitofemoral nerve, as I told you, just understand the location. So this is the front side femoral triangle. Okay, front side of the hip femoral triangle. So we know the VAN, vein, artery, nerve, from medial to lateral. This is the In this way we find the artery, vein artery nerve. Okay, so this yellow one is the nerve, red one is the artery, and if we see that just above the red one another yellow part is there, small yellow part, so this is the genitofemoral nerve femoral branch. I'm not talking about the genital branch, that is actually part of the spermatic cord wall, so we will not find that, so we can find only the genitofemoral nerve here on. And this you can see that genitofemoral nerve, how it divides in the femoral branch and genital branch. Remember, hip joint is supplied by capsule of the hip joint is supplied by these different nerves from the anterior side and posterior side. So though it is, I mean, multiple nerves are there for supplying it. Okay. Some vessels are important, while we if we see that this is the femoral arteries, and then the biggest artery is the your profunda femoris artery, and from there multiple circumflex vessels are coming. So these circumflex vessels, lateral circumflex, medial circumflex, anterior circumflex, so these are there. So we just in front of the neck of the femur there are some circumflex vessels, okay, arteries. So if we want to do an intervention for joint diffusion, remember when we go for an intervention in the joint arthritis, we do not go between two bones. We inject in the recess in many areas, not that every area we do not go. So here in the hip bone, we do not need to go between two bones. We inject in the recess, fluid will go inside the joint. So in the recess area is found over the neck. So here over the neck these vessels are also there, so while doing an intervention we must take care of these vessels so that we are not puncturing the vessels. Okay. Now let me show you the ultrasound anatomy. Okay. Remember, uh, this much was this much anatomy whatever I have said, these things are to be remembered while I will show you the ultrasound anatomy. Okay. So now probe selection and patient positioning, so we can understand that most of the time anterior and posterior hip is very deep, so we need curvilinear probe. Anterior hip, if it is a hip joint, so in this area you can see in this picture, so hip joint area most of the time we see by curvilinear probe. But if it is a superficial nerve we are seeing, say meralgia, for meralgia paresthetica, or for I mean like genitofemoral nerve, then we will use the linear probe. And medial side most of the time linear probe is sufficient, lateral side linear probe is sufficient, but not in the posterior side and not in the anterior, for anterior or joint recess. In those two areas we need the curvilinear probe. Okay. Because it is deep, that's why. And then comes patient positioning. So either patient will be lying supine, or patient can lie prone also as per need, or in the lateral decubitus also, that is also possible. And when we are seeing the joint, it is possible, this is a called frog like decubitus. So in this way also, this elbow, I mean knee is a bit flexed, and hip is externally rotated. So this one actually, this position also you can use for examining the anterior hip. So let us see, these are some recordings actually. So I'm showing you that first we will start in a short axis view. This is a short axis view for femur. Okay. Remember, there are two things in ultrasound, one is plane and one is axis. Plane is fixed, that is either coronal plane, sagittal plane, axial plane, so these are fixed thing. There is no I mean nothing to think much. But when we talk about axis, then we talk about a specific thing. Like if I say that I am seeing short axis, then it doesn't mean anything. I have to say that I am seeing short axis of femur. So here I am seeing starting from short axis of femur, and then I will go up to the neck, up to the greater trochanter area basically. So you can see this starting point, this round structure tells you, and much deeper now round structure is telling you that you are on the shaft of the femur. So this is the shaft of the femur. Okay, so just see. So as this part, you can see one part is becoming a bit straight, as a bit straight, this part. Why it is becoming a bit straight? Because you are on the lesser trochanter. Okay, lesser trochanter or area, this area is becoming a bit straight. So after that, now I am going even up. So here, oh, okay. So here, lesser trochanter area, then I am going even upper side. Oh, some issue. So at this point, you will see there are two lines. Two lines comes like this. So when these two lines comes like this, then you know you have come to the greater trochanter. Okay. So this is not very important, but to see that shaft looks like this. This one is lesser trochanter, and for greater trochanter, it looks like this, more of a this. Okay. So this is the, and it is in the I mean lateral side becomes a bit bigger, and like this. Okay. So why we can go to the our intention is to see the joint. Our intention is to see the head and neck area, because neck area is important for recess finding, and joint is we want to see that whether there is an arthritis or effusion or not. Okay. So either you can start from the shaft area and go to the greater trochanter area, then fixing one side under your probe, you can move the other side, and you can see that full head neck like that. That is also one technique. Or another technique is just search the head of the femur. Okay, so here let us search the head of the femur. Okay, here it is already searched. So this round thing is the head of the femur. Here we are seeing the labrum. Okay, so remember when we see the head of the femur, then so this is the head of the femur. Okay, we see a thin line of cartilage. We see a thin line of cartilage also. So this is the head of the femur. So always first use, I mean, in a very thick patient, it becomes very difficult to localize that where is the, joint. Where is the joint? So just first step is to find the head of the femur. So as soon as I find the head of the femur, then it becomes much easier to find the neck this side and this side labrum. Okay, so that is just positioning of your hand. So this is the acetabulum. This is the acetabulum. And where is the labrum then? Labrum is this area, this triangle. Okay, this side is the labrum. Okay, let's see. Here there is one important thing. So you can see there is this, oh, there is a small line here. There is a small line here. So if you see carefully, it line you can see. So actually this part is labrum. Remember, labrum is a fibrocartilage. So that's why just below labrum, we can see the bone. We can see the bone. But this side, acetabulum is a bone. That's why these are all acoustic shadow. We cannot see below that. Okay, so this is the joint we can understand. And as I told you, above the joint, the muscle, whichever you see, that is the iliopsoas. So what is this muscle? This muscle is the iliopsoas, whatever it is. Above the joint, you will see only iliopsoas. So this is iliopsoas. So, and basically this is the iliopsoas tendon. Okay, remember iliopsoas. So we will see in other picture iliopsoas tendon better, but this is the iliopsoas tendon. Okay, so we are seeing a bit below. That's why it is looking like this, and it is not in the short axis also. So anyway, so you see the labrum is a separate thing. It is a separate thing. Okay. So at present, if I hold the probe like this, so you can see in this picture, this is the neck area, and this is covered by capsule. This is the capsule of the joint. Okay, this is the capsule of the joint. So if if I inject from here to here, then we will directly, this is the recess of the joint. From here, the fluid will flow inside the joint. Okay. Okay. I'm going in the next picture. Okay, hip capsule folding at the neck. So here one important thing, as I told you that axillary arteries are there, circumflex arteries are there, artery or vein actually. So you see in this middle part, there must be a pulsatile artery. So this one, here you see the pulsatile arteries. Okay, these are circumflex vessels. So this is the way how we hold the probe. Okay, so this is the way how you hold the probe. So here I have come to show. So this is the head. This is the neck. Okay, this part is circumflex vessels. These are all capsule. This is capsule. Basically, this capsule is like this. There are two layers of capsule. Lower part is a bit thicker and upper part is thinner. So your needle will come from here and to here. You will inject here, but you must not puncture the vessels. So if you see the artery here, so either you come from, I mean, like from, you hold the probe like in that way that you do not puncture the arteries. So your actually our needle should come in the neck area, in the recess area. Okay. Okay. So though pen block is not important for us, it is for I mean like in regional anesthesia they practice, but it has some relevance for a chronic pain physician also when we go for denervation of the hip joint. So here actually we are seeing, so at this point you can see the right one, how I have hold the probe. So first thing you see, so this is what I was saying, that you first search always the head of the head of the femur. So this is head of the femur, very nicely seen. We can understand, and a very thin line of cartilage we can see. Now, as we are on this head of the femur, okay. Now, if I go a bit medial to this side, parallelly, medial but parallelly, then where I will go? Then I will go over the iliac bone, over the iliac bone. Okay, so that is what I am doing here. First, I am searching the head of the femur, and then I will go a bit medial. So I'm going medial. Okay. So if I go in this way, in the medial part, so now we are not on the head of the femur. It was lateral. I have gone a bit medial. So what we can see here? So this side, this side, so this area. So this area is what? Anterior inferior iliac spine. This side is here actually iliopubic eminence. Okay. And here, of course, will be pubic symphysis. This side, pubic symphysis, you will get. Okay. This is the pubic rami. Pubic rami. So, above that, the muscle, what we are seeing, this complete muscle is iliopsoas. Okay, complete muscle is iliopsoas. But of course, it is not over the just head of the. It is it is we are not seeing the muscle over the head of the femur because we have come a bit medial, but it is the same muscle which is there over the head of the femur. So this is the femoral triangle. You can see the femoral vessels. So you can understand more that this is iliacus muscle. Okay. So it was anterior inferior iliac spine. You can see left side anterior superior iliac spine. Okay. So this one is anterior superior iliac spine. AOS IS anterior inferior iliac spine. Okay. And this is the iliopubic eminence, pubic rami. So all these things. And this area is completely iliacus muscle, not the iliopsoas, basically iliacus muscle. As I told you, iliacus, that from that picture in anatomy, what I showed you, that this side is the medial fibers of iliacus, this side is lateral fibers of iliacus, but completely iliacus. Okay. Psoas tendon is only, yes, this part, this is the psoas tendon. Okay. And small part of psoas muscle is there. Okay. This is the psoas tendon. When you go medially, you see a bit of psoas muscle coming. But if you come laterally, you will not see this amount of muscle. Okay. Okay. So this is necessary when we go for the denervation purpose. Then let us see the front side in a short axis manner over the head of femur. Again, the head of femur, but now I have put it in such a way that we can see the muscles clearly. And so let me start from here. So you see very nicely, you can see there are two tendons. This is psoas tendon, this is iliacus tendon. Okay. This is iliacus tendon and this is the psoas tendon. And this is completely iliacus, completely iliacus. Okay. Now we are moving laterally. So at this area, we know that total 4 muscles was there. So over the femoral head, iliopsoas, we have seen. So what other muscles? So I think most of you know this is a, oh, just a minute. So most of you know, I think. So I'm coming, you see the ultrasound probe, I'm coming from medial to lateral. Anyone can say what is this muscle?
Sartorius.
Sartorius.
Sartorius. Anyone can say what is this muscle?
Rectus.
Rectus femoris. And this muscle, what we are seeing?
Tensor.
Tensor fossa lata. Okay. So what can we search here? Between this, so we know from this muscle, no, that this rectus femoris, it will insert in the anterior inferior iliac spine, and these two muscles, tensor fossa lata and sartorius, they will insert where? Anterior superior iliac spine. Are we seeing something here? This part, can we see something here? This
LFT.
area. Yes,
Lateral
this is
femoral.
the area for lateral femoral cutaneous nerve. Remember, when I'm coming more laterally, so this area is actually covered by gluteus medius and minimus. So remember, from the front side also, we can see a small part of medius minimus. That is, don't think that all gluteus, everything can be seen from posterior side only. Insertion, we can see medius minimus from the front side also. Okay. Now proximal attachment. So this part already I told you. So now it is going, it is entering here. And this one is the anterior inferior iliac spine. And you can see the bird beak appearance of the anterior inferior iliac spine. At the anterior inferior iliac spine of the rectus femoris. Direct tendon. Rectus femoris has multiple tendons. It has three tendons actually: direct tendon, indirect tendon, and one reflection. So this is actually direct tendon when we are seeing when it is coming and joining in the anterior inferior iliac spine. Now what we can do from here? So we go more to see other two muscles. So this is another muscle, this is another muscle. So we are going more. I have decreased the depth, and you can see these two. This is one tendon, this is one tendon. They are coming and joining in the anterior superior iliac spine. Okay. So pectineus and adductor muscle I am not showing, just to show you that in front of this femoral triangle, all the vessels, nerves are there. Then first muscle, just here, when we see this one, so this muscle, this big muscle, this is the pectineus. It forms the floor of the femoral triangle. So this is the pectineus, and here three muscles are there. Okay, so this one is the adductor longus, adductor brevis, and adductor magnus, and this is the pectineus. Okay. This is the femoral side, femoral triangle when I am showing you. So here, so this part you can understand that this is the iliacus, and this is the nerve, femoral nerve, and this is the femoral artery. So here actually there is one structure, small structure, that is the genital branch of genitofemoral nerve. It is moving like this. So this one is the genital branch of genitofemoral nerve. So you should know that where to search. Okay. You need a very nice probe, very high quality probe to see this small nerve. Okay, lateral femoral cutaneous nerve. So rectus femoris, sartorius, tensor fascia lata. In this area, we will see the lateral femoral cutaneous nerve. So just see these two. So this is the nerve, big nerve. This is the nerve. This is the nerve. Okay. This is the nerve. This is the nerve, lateral femoral cutaneous nerve. So this one. Okay. So here you can see it is over the sartorius, just not between these two. It is over the sartorius. You have to search it. This one already I have shown. This one is the genital branch, femoral branch of genitofemoral nerve. You can see this one. Okay. Lateral hip. Now in the lateral hip, so I'm starting, actually you can start from below, then it will be rounded structure, and then suddenly you will see these facets. Okay, so this one is anterior facet, lateral facet, posterior facet we are not seeing here, but then anterior facet is for gluteus minimus, gluteus minimus. This is for medius, and this is also for medius. This is also for medius, and maximus actually here, this area. Okay, so three facets are there, 1, 2, 3. So we can see the facets here, and why we need to see it here? We need to see for the tendinous insertion. Tendinous insertion. So this area, this tendinous insertion is for gluteus medius. And why we need to see the gluteus medius? See, subgluteus medius bursitis hardly we can see. Subgluteus minimus bursitis hardly we can see, but we always see subgluteus maximus bursitis. So you need to understand where to search the subgluteus maximus bursa. So remember, over the medial over the lateral facet, this is the lateral facet. This part is covered by the tendon of gluteus medius. Okay, so above the gluteus medius tendon, at this area, you will search for the bursa, gluteus maximus bursa. Above that, subgluteus maximus bursa. Above that, this is the gluteus maximus muscle. Okay, this is the gluteus maximus muscle. So this area must be understood that when we are seeing the facet, just above the facet, you are not seeing the bursa. You are seeing between the tendons of subgluteus medius and the gluteus maximus muscle. There we see the subgluteus maximus bursa. So here, if we suspect a case of tendinitis or tendinosis of gluteus medius, so from here, after seeing the short axis, we can see them in the long axis also, both gluteus medius and minimus. So here you see one small line is there. This bursa is also like our shoulder part, subacromial bursa. So this is also like deltoid. This small line is there. This thin line is there. Okay. So if there is a fluid is collected in some patient, if you see, so you can see this line. So here, if some fluid is collected in some patient, then you if there is a subgluteus maximus bursitis, then do not expect that fluid will be staying here. Fluid will be staying in this area, posterior side here. Okay, so you have to see the posterior side also whether there is fluid collection under the gluteus maximus or not. This is the gluteus maximus muscle. Okay, here is the bursa. Here is the bursa. Okay. Okay, here I have another picture of gluteus maximum. So you can see this line. So with movement, with leg movement, we can see that one part is going in the right side, one part is coming in the left side. So between these two parts, this is the bursal line. This black line is the bursal line. Okay. If we, okay. IT band. So IT band, this is the iliotibial band. This one doesn't actually, iliotibial band syndrome doesn't cause hip pain. It causes more of a knee pain, lateral side of the knee pain. But of course, it can cause snapping syndrome. It is called external snapping hip syndrome. Okay, there are two internal snapping hip syndrome and one is external snapping hip syndrome. So these can cause external snapping between the iliotibial band and greater trochanter. There is a friction. Okay, so here we are. You can see I'm seeing in a short axis manner. So in the short axis manner, if I short axis over the hip, if I put the probe. So this one is gluteus maximus, we can understand. And from the front side, tensor fascia lata also will be seen, at present not seen, but it will be seen. And in the middle part, this area is the iliotibial band. Okay, so iliotibial band from the middle, so where the rubbing will take place over this bone and the iliotibial band. So when we will see in a long axis manner, it will be seen more clearly. So let's see. So now short axis. So this part, middle part is the iliotibial band. Now I am making it long axis. So you can see this is the long axis. This is the iliotibial band. And so this is the iliotibial band. And rubbing will take place in this area, middle part, in this over the facet. So here you see no other structure is there. Okay, it is directly the bone. This is the bone. And above that, this is the iliotibial band. So rubbing will take place here. Okay, so that causes the external snapping hip syndrome. Okay. So posterior hip again. So I told you that first this is the position number one. Position number one, which I showed you that this is like a slope. This is like a slope. So what we are seeing, the upper part, it is the upper part. We are seeing the gluteus maximus. This part is the medius, and small part is minimus. Why I am saying that this is medius and minimus? Because between medius and minimus there is a vessel. This is called superior gluteal artery. Superior gluteal artery. So you can see here, it will be pulsating. Okay, it is this should be pulsatile. So here also a bit pulsatile is there. Yeah. So this is maximus, medius, minimus. So this is the position number one. I am going in the position number two. There should be a gap coming in between. So then we will know that we are in the greater sciatic notch. So this is the gap. This is the gap. Okay. So here, as soon as the gap has come, this is one side, this is one side. Okay. This is the gap. This is greater sciatic notch. So at this area, gluteus maximus, you will see this is the gluteus maximus, but below that, this is the piriformis. Okay. This is the piriformis. So in this position, you can put the probe like this and you can do intervention from the lateral to medial direction. Okay. In the piriformis muscle. So this is the piriformis. Second one. So remember, the piriformis is a bit more hypoechoic, more black than the overlying gluteus maximus in this region. Okay. So third position, piriformis to pudendal. So here what we will see this part, lateral side, this lateral side. So this one will become straighter, will become a bit straight like this. Okay. Now it is smaller, it will become bigger and straight. At present, it is in the second position. We are seeing some bone here, and piriformis here. So it will go in the third position now. It will become straight. Yes, so this has become straight. So at this point, what we are seeing, so if I hold like this, okay, so we can see two lines here. So up to this much, this is the bone, and at the same level, another line is here, and above that, another line is here. So upper one is sacrotuberous ligament, and this one is sacrospinous ligament. Okay, so between them, we will always search for pudendal nerve. We will search for pudendal nerve. Remember, the pudendal nerve is medial. It remains here, and pulsatile artery is pudendal artery. So with this needle positioning, my needle will come from the medial side to inject in the lateral side. Okay, like this. I will not go in the opposite direction, because why? Otherwise, I will puncture the artery. Most of the time, it is possible that artery is just a bit covering the nerve, not covering, but still you can puncture the artery. This is the nerve actually. So it is better to inject from the medial side. Okay. So see, in this view here, pulsatile. No, this one is the pulsatile. Yes. So you can see this part is bone and this is artery. This is artery and here nerve was there. So now we are going to the fourth position. So this was, you remembered that this already I talked. Okay. So fourth position is when we are going to the sacral ischial tuberosity. So it will come over the third position. So this was the third position. Okay. So as soon as we come in the third position, we see the pudendal nerve here. It's okay. But above this ischial spine, we see the gemellus superior inferior and obturator internus muscles here. And also we see that above these muscles, the sciatic nerve comes laterally. Okay. So we'll see the sciatic nerve, how it comes laterally. So this one is the sciatic nerve. It is coming. It is coming. And now at this point, this is, I think you all know, because it comes in regional anesthesia, because we see the sciatic nerve between the gluteus maximus and quadratus femoris here. This is the sciatic nerve. This is the greater trochanter. This is the ischial tuberosity. Okay. When we are seeing the ischial tuberosity, of course, a bit below, then we will see the tendons. Then we will see the tendons of conjoint tendon. So this part actually, so this part, here we see the conjoint tendon insertion and the semimembranosus tendon insertion. So for seeing the ischio-gluteal bursitis or the this tendinopathies of these areas, we need to see the ischial tuberosity. This is the last position for tracing in the hip area. Okay. Other things are also there, like we have come from above to down, but you can start from below to up also. Just at the gluteal fold, if you put the probe, suddenly you will see a Mercedes-Benz sign, like a sign that one is like this, one is like this, one is like this. If you see very nicely, you will see that this can be seen just at the gluteal fold. So what is this? This one is sciatic nerve. What is this? This one is the conjoint tendon. And this side, there is the semimembranosus tendon. Of course, this part, this total part is actually the conjoint tendon. Semimembranosus tendon is here actually. This is not the part of your Mercedes-Benz sign, but still, so you can see. This is the conjoint tendon. This is the sciatic nerve. So at the gluteal fold, finding the sciatic nerve is very easy. And so here is a spermatozoa-like structure, spermatozoa-shaped structure. This structure is nothing but the semimembranosus tendon. Okay, so we will start from below actually. So from here. So now we are starting from below. See, semitendinosus, semimembranosus. This is biceps femoris. Lateral side biceps femoris, semitendinosus, membranosus becomes small. Semitendinosus. So at this point, what do you see? This is the sciatic nerve. This is the sciatic nerve. Other parts are getting formed. Okay. So here, when I'm going up, so this is a spermatozoa-shaped tendon. So this tendon is semimembranosus tendon. This side sciatic nerve, and this is the conjoint tendon forming between the semitendinosus and biceps femoris. So this is called this part called the Mercedes-Benz sign. So this is one side, this is one side, this is one side. These three things are Mercedes-Benz sign, and this is the semimembranosus tendon. Okay. So to understand the structure, you can start from below also, you can start from above also. Okay. Multiple other structures are also there, but I will not show more things. Some video section, just see. I think. So this is a sartorius tensor fascia lata. We are injecting inside the. So this is the lateral femoral cutaneous nerve. We are injecting over the lateral femoral cutaneous. So here you can see the nerve is inside the sartorius muscle. Earlier, the picture which I showed you, that was above the sartorius muscle. So this nerve has to be searched. It can be inside, can be above, can be in between, can be below also. So this has to be searched. So this is the nerve. So in a long axis view, if I see the nerve, so this is the nerve. This is the nerve. This is the nerve in long axis view. This is a hip joint injection. So our needle is coming in the recess, and these are the vessels, circumflex vessels. So we are not puncturing the circumflex vessels. We are put in such a way that it is coming cranial to it, and in the recess we are injecting the fluid. So joint treatment is same for all areas. Either it is knee joint or hip joint, either you want to regenerate or you want to give hyaluronic acid. So whatever, the treatment, most of the time, treatment strategy is same. Ankle anatomy, if I say, then it will be too much.
Yeah, Dr. Devjyoti, we require one more complete session for ankle. It is difficult to cover. It will take next 1 hour.
It will. I don't think at
Anshu?
present.
Yeah. So that was
I
a
think
wonderful presentation.
this needs only hip. Let me. I mean, we can complete only hip up to this much, and ankle will take too much time. Then again.
True.
Very good
Ankle
presentation,
itself
sir.
it was very wonderfully covered. You made that complex hip. I think many of us are a bit skeptical about the hip because not common interventions are done there, and not a common except for the piriformis. But you made it so simple that I hope all the fellows must have gained so much knowledge and insights into the hip joint. What I suggest is that all of you should go and practice hip in next 2 or 3 days so that it fixes in your mind. Otherwise, it's volatile. Thank you
Ma'am,
so much.
there is some
So with
questions.
this, any questions? There were few questions in the chat box. I'll just go through that. Where can we put the needle in iliopsoas area for denervation?
Yeah, denervation area. Yes, it is like pen block only. It is the same thing under the iliopsoas tendon and above the pubic iliopubic eminence, above the bone and below the tendon. There actually we do in a denervation of the femoral nerve articular branches, genicular branches or articular branches of the femoral nerve. You can denervate. Okay.
The next question is, can we target Alcock canal for pudendal?
No, pudendal nerve under ultrasound, you have to go between this only. Yeah, between these two sacrotuberous and sacrospinous ligament. Alcock canal, that is done we used to do in a lithotomy position by, I mean, it is a blind technique. Ultrasound, I don't know why we cannot do probably.
Yeah. So here the Alcock canal is not visible in the posterior aspect at the ischial spine. It is just the nerve along with the vessel. Yeah, that's all.
Yeah.
So thank you once again, Dr. Chinmoy. Very wonderful session.
Thank you. Okay.
Thank you, ma'am.
Thank you.
Thank you, sir.
Okay, thank you. Okay, good night.
Good
Thank
night,
you.
sir.
Good night.